So, we're going to Turkey.
Thank you. Thanks, Francisco, and thanks, Kelly, for the invitation to come present. So my title is different because in order to talk about screening, I have to give you a bit more context. And really was listening through the day, and I'll touch on some things I think that are relevant. I know tomorrow morning I'm talking about exercise, and so I gave a bit more backdrop and to sort of set the stage. So I think it's helpful, actually, I'm going to talk a bit about what HAND is, why it's important, how it affects day-to-day functioning, what are the rates. We have good data in the US and Canada. There's rates coming out in other places around the world as well. And we'll sort of can speak that as we go as well. But just to ground people, these are the kinds of things we heard about episodic disabilities. So this cognitive impairments in HIV, slowing, short-term memory, working memory, multitasking, word finding. These are all the kinds of things that you see in HIV. They're actually very similar we see in MS. They're very similar we see in mild brain injury. And I guess my first point to mention is that HIV can cause a brain injury. And if you think of rehabilitation, we don't usually talk about it like that or think about it like that. I think that's important. That's one context I think that's very helpful. And we should be talking about more like that. We see a lot in the news, obviously, about concussions and sports players, hockey players and football and so on. This is a brain injury, so it's important to, I think it's helpful to think about it like that. The other thing, because we talk a lot about aging, is that the same things that you see with HIV, you see with aging. That's what makes it difficult to sort of disentangle when I talk about screening. But just on the right there, we all peak at 20, so in terms of your cognitive abilities. So this is speed of processing, but multitasking the same way. So you get really good, and all of a sudden, as you get older, you just can't run as fast, you can't do things as quickly with your brain, and certainly for multitasking. So that's an important context, because that's the difficulty with T-things that we hear of accelerated aging. I don't use that term a lot, but this is what it makes it complex as a neuropsychologist. And so these are when you talk about HAND, or HIV-associated neurocognitive disorders, there's three things, and there's two ways of thinking about it, but they're all under this umbrella. Everybody knows about dementia. It doesn't happen very often. It did happen very often when the medication, when combination therapy wasn't around. But certainly it's gone down since the availability. It happens probably in 2 or 3% of people that have advanced HIV. So it doesn't happen very often. It's the two other conditions, the green and the blue, the mild neurocognitive disorder and asymptomatic neuropsychological impairment. That's the new one that has some controversy about whether this is important. We'll come back to that, because I think, bottom line, it is important to identify. I'll tell you why. So that's what I'm going to talk about. You see at the bottom here what it means to have sort of these two milder conditions on the left. So both have mild neurocognitive impairment in these two domains, but one has functional impairment, the other doesn't. So what does that mean? So somebody is saying that in the case of the mild neurocognitive disorder, people may not be able to work, but they may still be working and have difficulty managing. Or but in the other case, the person says, I don't notice anything, I'm fine. And so that's the important context in terms of the differentiation between those two conditions. And there's a lot of effort, or a lot of interest in this. And you can see just a slide showing you this is a new category, a new nosology. We've known it for a long time that it's not like this is something new as of 2007. We've known this, but just the way we've characterized these three conditions, it used to be just two. And you can see it just escalating the number of sort of the efforts that are going on around the world trying to figure these things out. I want to emphasize, particularly from a rehab and a point of view, is that when I started at St. Mike's or at the Wellesley Hospital in Toronto, about almost 20 years ago now, the people I was working with felt that identifying mild neuropsychological impairment, really, if it's mild, it's not significant. I can tell you it's very significant, or can be very significant. And so there's obviously things that all of you know about how this can affect people's work, but it's also socialization. We'll come back to that, because that's an important element that probably doesn't get enough attention in this area. And I think it's a ripe area for interventions to support. There's no question that people have some mild impairments can affect their ability to manage medications. But in terms of quality of life, I want to emphasize the self-confidence piece in mastery. Because, even slight changes in brain functioning can really shape a person's sense of self. And I think as professionals and interdisciplinary professionals, that's probably one of the most important reasons why I sit down with every person that gets an assessment and we talk about what that means to them. What's the context? How are they managing it or not? And you know, in research in this area, very few people are actually seeing patients. So this is an area that really needs much more effort to sort of understand it. I say that I've trained with, grew up in the field of neuropsychology, and all these people that publish are just, you know, doing very well in terms of their academic work and publishing great papers, but they don't see patients anymore. And that's a missing piece. So I often get the question, well, so if people aren't working, how, you know, is that a concern as well? It definitely is. So there's lots of ways that mild impairment can impact a person's functioning. May not go to bars or restaurants because the noise is distracting. You know, forgetting names can often be a time or can be very uncomfortable. So these things actually have real life significance when even they're mild. And we've started to do some work, and Francisco just got a grant to do this in more detail, but working with, here's the work finding, Stephanie Nyson. I worked with her and some students, physical students at U of T, to start ask people living with HIV their experience of hand. And so these are the first two papers that have been published about this area. So, you know, 30 years later, we still not really, from a rehab context, we need to do a lot more work to understand the nuances of how people are living with HIV and how they're managing hand. And Francisco and I and some others are really keen on figuring out what we can do better in terms of the rehab context for these things. Depression is also very common in the context of HIV, and this is what makes it more complex in terms of reporting, because people who are depressed, or if you're upset, if you're feeling fatigued, you're going to report trouble with your memory, trouble with your multitasking, and so on, which may be completely related to depression, and brain could be just fine. So that's an important context. I'm sure you guys know we'll be talking about more if that's in the discussion. And I just want to show you here how strong that affects. So this is previous work that we've done, but depression and symptoms of cognitive symptoms correlate to one side. That's a very strong relationship. So it means that as you get more depressed or have more mood symptoms, your cognitive symptoms will go up. And so you can tease out the objective cognitive impairments, but you often need large sample sizes to see it. And it's really quite, in this next figure, you'll see that depression, you can see 3/4 of the size of those bars. So that's the depression effect. That's a person's mood or their feeling that moment, how that can influence reporting of cognitive symptoms. You can still find the neuropsych piece, but it's a smaller element. When I started, I thought, well, maybe there's a way of asking questions in terms of cognitive questions with clients, with patients, and that could tell us something about what's going on. Turns out it's a flip of a coin. So, and I always tell, you know, working in the context in the hospital, you don't need to diagnose dementia. When it comes to these milder problems, you really need formal tests, and that's, I was asked to talk about the screen, which I'll get to, but this is the backdrop and the context for that. What's important, this is a study that was published back in 1987, I think, or 91 or something, group in Seattle. But basically what they did was they treated people who had cognitive symptoms and who were depressed, and gave them neuropsych before and after. And this, what basically happened is that you treat the depression, their symptoms went down considerably. So this is why it's important when there's mood or other related mental health issues, just treat them. And there's no contraindication. It can help people get better regardless of knowing what the other stuff is going on. So there's no reason to wait. It's one of those things, just treat right away. It's interesting that we haven't seen more trials like this. This is almost 20 years ago, or more than 20 years. So in terms of the context for hand, there's some really nice work done in the US called the CIHRRC. So if you're interested in learning more about it, look at CIHRRC. And basically, the question is, you know, we were thinking that have the rates changed before and after the introduction of combination therapy? The answer is no, not really. So the numbers are about the same in terms of these, particularly the milder conditions. There's a tendency that people sort of living along with HIV have more of a chance now of developing these conditions, and I'll show you that in a moment. But I want to emphasize too, a lot of the work so far, and I'll show you some Canadian data in a minute, has been with very controlled studies. And the charter really has these were 6 sites across the US, has really helped us understand the complexity of what's going on in addition to just the HIV. So I'm not sure if you can see at the back, but you know, cerebrovascular events and special education, low reading level, and depression, and so on. These are things that happen in real life. And so this is what we're really trying to understand now, is how you tease all these things out in the context of hand. Here's Canadian data. So as I mentioned, dementia doesn't happen for this 1,000 people that were being followed in Toronto. But you see the mild neurocognitive disorder happens about 1 out of 6 people. And this is the more common one, so 1 out of 3 is asymptomatic neuropsychological impairment. So that's generating a lot of interest and a lot of controversies. You know, here's another diagnosis. Is it meaningful or not? And so when we look at that, up until very recently, there hasn't been any data sort of looking at if that's useful in terms of prognostics. So this is the group I trained with, Igor Grandy's group in California, and basically what they showed was this ANI category, asymptomatic neuropsychological impairment, carries a 3 to 5 time risk for developing symptomatic pain. So in a very nicely controlled way, they've shown the significance of this. And so this is kind of like, the ANI is kind of like having high blood pressure and the risk for heart disease. So high blood pressure is something that, you know, sometimes when you're feeling stressed, oh, my blood pressure's high. But the real thing that you want to pick up is when it's high and you don't know it. And so this is where this is sort of analogous. So we can use a good test to pick up this condition. And we hope that through understanding this better, we can then diagnose it earlier, figure out what treatments can be better to minimize it and help people get better over time. I think the more there is this goes unnoticed and not picked up, the chances of it moving to mild neurocognitive disorder and to a place where it's going to take more to actually make it better. And I just wanted to say how depression is one of those factors that show to be over time important in that context. So, and here's our own data. We showed a 2-fold increase in this from ANI. So we use a smaller battery in our follow-up in our cohort. I think if we had a more complete battery, we might, and we have people who don't have as many comorbidities as well. Our rates are probably around 2 to 3, and this is our first look at it. We'll continue to follow it. Certainly tells us it's important to pay attention to. And like the San Diego group, show the depression and some other things that were important in prediction. I want to point out smoking. So one of the things I'm going to get to in the second here is about comorbidities. It's actually my next slide. So cardiovascular risk factors have only begun to be explored in the context of hand. And so we need to catch up because that's going to be an important, the whole notion of, from in a rehab perspective and thinking about exercise, it's really the way to go. Cardiovascular issues, lipids, and diabetes, these are all things that we see are complicating HIV and certainly complicating the picture in terms of brain function. Keeping your vasculature in good shape is just important, whether you have HIV or not, but it's even more important, I think, in the context of HIV. As you probably know, depression, and Richard just did a nice review of depression screening that is out there, but again, depression is something you want to pick up as well, showing related to morbidity and mortality here. And here's another study, and it's funny how these things are, 20 years old. This is a study of us, it's 2001 or 3, from the MAX cohort in the US, showing how important depression is in the context and in other education and IQ-related things in terms of progression to dementia and survival. So we've known this for many, many years. We just don't think about sometimes those softer things that are really important. And I think that's where the field is changing, It isn't just about the numbers of viral load and CD4. It's about this other stuff that we've known now for a long time. And we need to be integrating it better into practice and rehab. Here's just showing these are survival curves, actually, that are incredibly powerful, sort of, in terms of prediction. So you don't usually see this kind of spread, but you add these risk factors up, and you have more time to dementia and time to death. So these things are really, those softer things that we, in our social science world, are really important to be paying attention to. In terms of screening, I'm going to get into the cognitive stuff in a minute, but I want to tell you about something that's also important, I think is going to be really helpful, and that is for physicians to be able to monitor just regular lab values that are collected as part of routine care. And so Amy Justice at Yale has done some very nice work with this VAX index, this Veterans Association Comorbidity Index. And they're basically things that are collected on regular blood panels, and with a couple other variables. And this paper actually showed that the VAX index itself is predictive of cognitive impairment, an odds ratio of 1.2. So this is important in addition to other things in monitoring. So every little bit of these prediction models are going to help. And just to tell you that our data supports this, and we've shown basically that not only is this way of monitoring regular lab values, but also over time, this is actually useful. So I can see us having screening measures both that we administer to people, but also things that can be paid attention to in terms of lab values that are going to be important together in really understanding CAN much better. So now getting the screening tools. So there's a lot out there. We just did this nice review about a year ago. And I'm going to tell you a bit about what we found and where we're going with this. And by the way, all of these slides will be available for people, I know, because I cover a lot of territory. People want to go back and look at things. I got more than 2 minutes. I have 20. So I got 12 plus 2. Okay. So for those of you who don't know, the dementia scale. Some people have heard of the dementia scale. This is something that's been around for diagnosed dementia. It doesn't do very well with milder dementia, milder cognitive disorder. But actually, if you do corrections for age and education, it does much better. And this is what it looks like. It takes 5 minutes. I heard about the MOCUS. This is another instrument that was developed in the context of aging and dementia that is there as well. There's some computerized assessments that are available. This is one called the CANPI, folks in the US, and then one from Australia called the Cogstate. You may have recognized it. All these sort of brief cognitive instruments. And when you look at all of them, so we did this review, we looked at all these screening tests, and we found 51 studies that met our inclusion criteria. But what's interesting, there's a lot of methodological flaws with this. So they're being used in a lot of different contexts. They often don't use a gold standard to compare it against. Most of them are done in developed countries. There wasn't anything done in Canada. Most of them are in English. And almost all of them were cross-sectional studies. So the sort of state of the art of this needs a lot more development. And what we found was, as I've already sort of hinted to, is that none of them were, first of all, developed for the milder conditions, and really few studies actually focused on how that you could differentiate between the dementias and the more significant. Having only one of the 4 use the gold standard is a problem, because you want to know, in a larger battery, what really gets, what you can pick up. And so if you don't have good criterion, your screening test could be just totally useless, right? There were some that actually had a decent level of sensitivity, but again, at 75%, even there, it's not something you want to do in a sort of in a broad clinical way, I think. The other thing I wanted to mention was around the dementia scale. So when you actually correct, if people are using it, when you actually correct for demographics, as we get older, as I pointed out in one of my earlier slides, we don't do as well on cognitive tests. But education, cognitive tests actually hang together with education as well. So the further you go in school, the better you do on cognitive tests. And so if you correct for that, you actually can do better, and even for the milder conditions. Still not perfect, But again, it depends on the context and what people are doing, but those adjustments can actually help. The area that I think of where we're going now is around tablets and phones. There's a guy in New York, Robbins, who has a phone application that's basically taking neuropsych tests that actually can be administered by social workers and nurses and other people, and putting it on a phone. And the San Diego group is also doing it on a tablet. So we're going to very soon have measures that will be transportable in clinics that actually use, these are the kind of tests you want to use. These ones that we've been using are not that good. These will take 5-10 minutes, and I think we'll have a lot better, these are pencil and paper right now, and I think that's still a barrier. Putting them on phones, testing them out to see how well they do, I think is going to offer us a lot more options. So in summary for this, before I spend about 3 or 4 minutes just on exercise, because I wanted to show you a few things, these tests, as I mentioned, we still need to do some work to actually have things that are going to be much more useful. And these briefer ones that are going to be on tablets will be very helpful. What else do I want to say here? So more is needed still. We're evaluating, we're actually got funding to address some of the methodological issues that I raised. So we got a grant from our government to study all these measures in the same people using a gold standard. So I'll show you that just quickly. So what we're doing here is testing all of these tools, and basically they get a gold standard, and I make a clinical diagnosis, and independent of that, people have these screening tests. And then we marry this together. So I do my own assessment, they get test scores, and you can see, when you look at this, all of those colors mean that there's discordance. And we've seen about 60 people now, and basically we had an impairment rate of about 60%, and this is now what we're starting to do, to look at how good these screening tests perform. So for example, a person's looking at normal versus mildly impaired, how well the individual tests that I showed you are performing. So you can see the hit rates here, of 60 to 70% are still not that great. So we're going to be able to compare all of these across the same people to see how they're performing. So this is going to really help move the field forward. At the end of the day, I think it's going to be the ones on tablets, which we'll also be testing in our lab, to tell us more about how those are useful. The last 2 minutes I wanted to tell you about is exercise, and I'll leave you with that. So combination therapy is done incredible things, but in terms of the brain, it hasn't done as much as we would like it to do. Having said that, there's a lot of data now emphasizing how important going on treatment early is. And so there's some good results there. But exercise. So what do we know about exercise? Exercise and aging, there's a whole body of literature around exercise in the brain. It's probably, even physical activity, as Darren was mentioning today, just how fast people walk is a predictor of their cognitive abilities in later age. I think this morning, Colin presented this data from San Diego, which shows that people who exercise, this cross-sectional data, are half as likely to have cognitive impairment. I think what's more interesting is that now it's starting to look at not just exercise, but social activity and employment. And if you take those together, rehab is never going to be about one thing. It's going to be about a combination of things. And that's where you guys are great, because you'll be looking at all those different dimensions. And you can see here the risk of impairment, higher is better. And if you look at one of these activities, 2 and 3, how the rates of impairment change. So which means that it isn't just about physical exercise, there's those other dimensions that are important in terms of overall health. I think we saw this one Colin had as well. Again, looking at exercise in terms of fitness. And the last thing, just to say, we're doing this brain fitness now. So in addition to physical exercise, brain fitness exercises, I think, have a lot of potential. So we're using this program from San Francisco. And this study what got me interested, was done on the Mayo Clinic in aging, and showed very promising results in terms of the benefits for brain fitness. These are the results that show that it worked. There's some pilot data from the US, and this is basically what we found in sort of our pilot work so far, that these are people tested before and after, and those with, we tested people who are both have mild neurocognitive disorder, those with dementia, and they both got better. And so we're now we've written a grant and we're trying to get funding to do this on a larger scale with an RCT. And what I want to point out to you is the right figure as well. These are the symptom burden. So if you reduce symptom burden by 28 to 47%, you're doing remarkable things to a person's quality of life, right? And so I wasn't expecting to see that much movement on the cognitive tests, but to see both is terrific. But I settled for just a reduction in the symptom burden, because that's saying how people are managing and compensating and so on. So lots of great things I think that we still need to do in terms of exercise, both physical and mental. And I'll leave you with this. This is one of the articles that should be in your materials, a nice review of what's the sort of standards, the clinical standards and treatment for hand. And then a very nice story about Maggie Atkinson from Toronto, understand lived experience of living with hand that you can get online from the positive side. It's a very nice personal account of how she's sort of managed living with HIV and cognitive related problems. So I'll stop there. Thank you.